Thank you. At the outset, always a gratitude, Dr. Mohan and entire team, Anjana, Dr. Ranjit, Pradeepa Madam, always a pleasure. My topic is to take you through now other part of the story, elephant in the room. Do you know if I screen all of us sitting here, 1/4 will be diagnosed as a patient with heart failure. We don't know. In particular, when I am saying heart failure, I mean to suggest that this is a heart failure with preserved ejection fraction. So, this is elephant in the room, and if you have got a diabetes, we need to have a completely different story. Dr. Sasank talked about treating diabetes when you are uncomplicated. If you have got a patient with type 2 diabetes with even a 1 cardiovascular risk, you need a drug that reduces the risk. And therefore, we need to have certain tools to take care of diabetes and heart failure together. I am not a cardiologist, I am an endocrinologist, so I have a little knowledge of cardiology, but then I would like to show you how endocrine enters into the cardiology space and comes at the front. An anti-diabetes drug becomes a frontline drug in the field of cardiology. Ladies and gentlemen, this is a simple classification of heart failure. You can classify heart failure into based on ejection fraction, with the progression, with time course, with the location. What I am going to talk here is a stable, chronic, left-sided heart failure regardless of ejection fraction. So we are not talking about acute decompensated heart failure in people with diabetes. Now, broadly, if you classify patients with heart failure, you classify into reduced and preserved ejection fraction. There is in between mildly reduced ejection fraction. Let's not bring into discussion. Somebody earlier it was classified under preserved ejection fraction. Someone having ejection fraction of less than 40 is called reduced. More than 40 was called preserved, but now between 40 to 50 is called mildly reduced, and more than 50 is called preserved ejection fraction. So how does this two type of heart failure differs? A very quick look into how these are different. Now, if you look at the reduced ejection fraction heart failure, the classical heart failure, people with a large heart, with a systolic dysfunction, you can see the picture of the heart, a weakened heart muscle was a reduced ejection fraction heart failure. On your right hand side, you can see how the preserved ejection fraction heart failure look like. This is a diastolic heart failure, that was a systolic heart failure. You can see the heart muscle mass is disproportionately larger, and therefore you have got a high LV mass to volume ratio. So it's a stiffened heart. It's not a dilated heart. That's the opposite difference between reduced and preserved ejection fraction. Now, if you look at the three-dimensional picture, how the reduced and preserved ejection fraction looks like, this picture tells you how the reduced and the preserved ejection fraction heart failure looks like. Clearly, the still photograph has shown you. Now you can see live photographs of reduced and preserved ejection fraction versus a normal heart pump. Now, why we are discussing it? As I said, this is an elephant in the room. Look at the data. If you are an elderly population, if your age is more than 60 years and if you have a diabetes, nearly 1/4 of them has some kind of heart failure. This is a data. You can see the large study published in Diabetologia suggesting how the heart failure is the issue in people with diabetes. Now, if you further classify into which kind of heart failure these people suffers from, interestingly, if you look the types of heart failure stratified on age, as the age increases, the chances of preserved ejection fraction heart failure also increases. And you can see this is disproportionately increasing over the time as the age increases. Now, why it is important in people with type 2 diabetes is at the end of the day, we don't want to lose the patient. These people die earlier. Look at the data. Whether you have got a preserved ejection fraction heart failure or whether you have got a reduced ejection fraction heart failure, the cardiovascular death and all-cause death is substantially increased. And you can see, interestingly, the people with, diabetes die almost 1.5 times higher compared to people without diabetes if you have developed any type of heart failure. So that's the introduction to the story. Now, how to treat it? There's an interesting story brought by SGLT2. In 2008, US FDA mandated that all new anti-diabetes drug has to undergo a cardiovascular safety outcome trial. And therefore, all new anti-diabetes drug such as DPP4 inhibitor, SGLT2, GLP1RA, or even newer insulin has to undergo a cardiovascular safety outcome trial. In the pursuit of showing cardiovascular safety, these are the trials done with SGLT2 inhibitor, starting with IMPAREG outcome trial in 2015 to the CANVAS program in 2016, DECLARE-TIMI in 2017, followed by VERTI-CB in 2020. We have got 4 CB outcome trials done with SGLT2 in people with type 2 diabetes, with or without cardiovascular disease, with or without heart failure, with or without CKD. And we knew that not only SGLT2 was safe, but it also reduced the composite of 3-PMS. So for the first time, you treated patients with diabetes to control blood glucose, but yet you benefited the cardiovascular composite. Now, although these trials differ from each other depending upon their baseline characteristics, so their primary outcome differed little bit, but if you look at these endpoints, there was one commonality in all the trials, that everyone reduced heart failure hospitalization. Remember, these people didn't have heart failure. If you look at the 4 trials, hardly 10 to 14% of the patients in these population had established heart failure, thereby suggesting that nearly 90% patients didn't have heart failure. And yet there was a significant reduction in heart failure hospitalization. This suggests that SGLT2 inhibitor has the ability to prevent heart failure hospitalization in people with type 2 diabetes who don't have heart failure. No wonder, if you look at the guideline in 2022, American Heart Association, American College of Cardiology, American Heart Failure Society, they rewarded them as a class 1A for primary prevention of heart failure. No molecule in the planet has got class 1A prevention of heart failure stamp other than SGLT2 inhibitor. If you look at the guidelines, the latest guideline, heart failure guideline, has come from the Japanese society. And if you look at the Japanese heart failure guidelines for the prevention of heart failure, you can see right at the top SGLT2 inhibitor with a class 1A recommendation. They have also included now finerenone in patients with CKD, with type 2 diabetes. So you can see the SGLT2 inhibitor in patients with type 2 diabetes, class 1A for prevention, SGLT2 in people with type 2 diabetes with CKD without heart failure, class 1A for prevention of heart failure hospitalization, and you can see finerenone in patients with type 2 diabetes with CKD even without heart failure with class 1A recommendation for prevention. So this is a tool to prevent heart failure hospitalization in people with type 2 diabetes who don't have heart failure. This is not for the treatment, for prevention. Now, needless to say that SGLT2 become now a class 1A drug for the treatment of heart failure, regardless of diabetes. An anti-diabetes drug came into cardiology, become a first-line drug in patients with heart failure, even if you don't have diabetes. So we learned a lot with SGLT2 inhibitor in patients with heart failure. So when those trial was done, people thought that if a drug has the ability to prevent heart failure, why don't we try in patients with heart failure? So the first one to go was the DEPA heart failure trial. As you all know, DEPA heart failure recruited patients with reduced ejection fraction, defined as EF of less than 40%, with or without diabetes. They randomized them to DEPA 10 milligram or versus placebo. The primary outcome was composite of CB, death, and heart failure. And here is the result. You can see the first trial to undergo in people with reduced ejection fraction heart failure, the DEPA heart failure shown 26% relative risk reduction in the composite of CB, death, and heart failure. And if you closely look at the number needed to treat to prevent heart failure was 21, exactly half of even statin. The best statin trial shown an NT of 42, this is a 21. This speaks volume as to how quickly this drug improves heart failure in patients with known heart failure with reduced ejection fraction. People said, oh my God, that's a great. Can you replicate the data? Can you do another trial? So next one to go was the IMPERA reduced trial. Now it is done with empagliflozin in patients with reduced ejection fraction heart failure. Look at the reduction, it was 26% there. Now the CB death heart failure composite reduced by 25%. Look at the NNT, it went down further to 19 number needed to reduce one heart failure hospitalization CB death event. So the second trial in patients with reduced ejection fraction, now with empagliflozin. Therefore, if you look at these two trials in patients with DEPA heart failure and IMPERA reduced, look at the benefit which has happened. Now, many of you might be looking at this balance and trying to look which one is better. Looking at this balance here, you can see both the drug actually reduced the different endpoint. The primary endpoint was CB death, heart failure, hospitalization. One can see some of the endpoint, for example, CB death and all-cause death was uniquely seen here in the DEPA heart failure trial, which was not seen in the IMPERA reduced trial. Contrarily, if you look at the renal event, it was significantly reduced in the IMPERA reduced trial, but not in the DEPA heart failure trial. So this graph is not to exactly compare which one is better than other, but to look at in composite as both the drug has a distinct merit to become a class 1A drug in patients with reduced ejection fraction heart failure. However, I know every one of you sitting in this hall must be looking and trying to believe that, so the DEPA looks to be better than the empagliflozin because they have got CB death, all-cause death data. But look at the volume of the primary composite reduction. It was higher significantly. This is the absolute risk reduction with either DEPA or IMPA in the DEPA heart failure and an IMPERA preserved, IMPERA reduced trial. Now, there is a distinct reason as to why these findings would have become different. This is not for a direct comparison. This is not a head-to-head trial to compare. I'm not going to detail. We published very recently to look at why this would have happened, in terms of DEPA heart failure and IMPERA reduced. The moral of the story is the IMPERA reduced trial actually recruited more sicker patients than DEPA heart failure. So there is a little imbalance, although both the trial was done in patients with reduced ejection fraction heart failure, but in the IMPERA reduced, people were much more sicker than the DEPA heart failure trial. That is the reason as to why there was certain difference in the cardiovascular endpoint between two trials. I am not going to detail. If you are a purist, you want to read why it has happened, this is written in detail in this paper which we wrote very recently. So the one part is over, that SGLT2 comes at the front line in patients with reduced ejection fraction heart failure. Then people said, what about preserved ejection fraction heart failure? Now you can see the trial which was done prior to the SGLT2 inhibitor, any molecule tested in the past prior to the SGLT2, be it ACE inhibitor, be it ARBs, be it ERNI, be it MRA, none succeeded. If you look at the p-value, there was hint that there could be some benefit, but it does not translate into a clinical or a meaningful benefit in terms of statistical significance. So there was no agent that actually had a class 1A recommendation in patients with heart failure with preserved ejection fraction. There are many drugs for reduced ejection fraction, but we had nothing in hand for patients with preserved ejection fraction. So people tested SGLT2 inhibitor in patients with preserved ejection fraction heart failure. So the first one to go here was IMPERA preserved trial. The patients with heart failure with ejection fraction more than 40% were either randomized to IMPA 10 milligram versus placebo, the primary endpoint being composite of CB death and heart failure. You can see there was a 21% relative risk reduction in the composite of CB death and heart failure that brought number needed to treat to 31. the first trial ever to show you any drug that reduces the composite of heart failure and CB death in patients with preserved ejection fraction was the Emperor preserved trial. The DEPA was next to follow. So dapagliflozin also undergone the similar kind of trial in patients with preserved ejection fraction defined as EF of more than 40% with or without diabetes, and they also came with flying colors. It was 21 there, it is 18% here in the delivered trial. The NNT was 31 there, NNT was 32 here, very neck to neck. The two different trial done in a two different category of patients, but having the same disease of heart failure with preserved ejection fraction with or without diabetes, with exactly similar benefit in the cardiovascular death and heart failure composite. Now again, if you look at this balance to look at, there is an absolute tie here in patients with preserved ejection fraction. Now you will not be biased to say that A is better than B or B is better than A. Exactly similar benefit in terms of absolute risk reduction if you use either DEPA or IMPA in patients with preserved ejection fraction heart failure. But again, my intention was not to compare, but to suggest to you that this benefit, rewards them a class 1A, level A recommendation in patients with preserved ejection fraction heart failure. But there was interesting finding in this two trial, Emperor preserved and deliver. The patients with a heart failure who have a higher ejection fraction, they look to have a better benefit with dapagliflozin. Contrarily, patients with a lower strata of ejection fraction tends to get a larger benefit with empagliflozin. Does that mean that I should differentiate patient based on ejection fraction? Again, answer is no, because there was a clear difference between two trial, deliver and Emperor preserve. The difference mainly being that in the deliver trial, they also included patients who had a reduced ejection fraction heart failure in the past, and that was not included in the Emperor preserved trial. That makes the difference why this graph looks like. Therefore, when you look at the graph, you need to know at the basic of how these things could have happened, because there is a certain difference between deliver and Emperor preserved trial. Because deliver included patients who had a past history of reduced ejection fraction heart failure treated, naturally they are going to benefit people with a higher preserved ejection fraction. Whereas in Emperor preserved, they did not take patients with a lower EF in the past, so of course they are going to get benefit with a lower ejection fraction heart. That's the simple explanation, no rocket science behind that. But ladies and gentlemen, what is interesting to see is, look at the benefit, the rapidity of benefit. Across those trials, you can see the benefit has started as early as 12 days, 13 days, 18 days, within 2 weeks after starting SGLT2. That's the, the merit of SGLT2. You prescribe the drug and your patient is going to get benefit within the next 14 days. It has never ever happened with any molecule in the planet, be it even a GLP-1RA. It takes time, but for the SGLT2, it was the quickest. So SGLT2 has got everything now, from prevention of heart failure in people without heart failure to the treatment of heart failure in patients with heart failure, regardless of ejection fraction, be it a reduced, be it a preserved, SGLT2 works everywhere. Now, why it is important to know that SGLT2 is the only drug in the planet that has got a class 1A recommendation today. Now, if you look at the guidelines, although the GLP-1 trial has now come up, Summit heart failure, preserved ejection fraction trial with tirzepatide shown CB death heart failure benefit. The pulled data from semaglutide shown benefit in patients with heart failure with preserved ejection fraction, but they have not given class 1A recommendation as of now. So as of now, if you look at the reduced ejection fraction, all the guidelines in the world given SGLT2 as a class 1A. But for the reduced ejection fraction, you have got many other agents, ERNI, beta blocker, MRA. But for the preserved ejection fraction, look at the right-hand side, you have got no drug other than SGLT2 as a class 1A evidence with preserved ejection fraction. Ladies and gentlemen, this suggests that it is a high time that no deserving patients having type 2 diabetes should be withheld SGLT2 unless there is a strongest reason to stop this GLT2 inhibitor. Thank you very much for your patience listening.